Hello, everyone. So this video is going to be an overview of E&M and just the section like in general, and then also the common guidelines. We are going to be jumping back and forth a lot between the manual and the PowerPoint. I'm not actually going to do any walkthrough of the questions at this time because there's just a lot to cover in terms of just the guidelines and how to use the manual. But hopefully, as I'm walking through it, it'll make sense how to answer some of those questions when you're looking at E&M this week. So I will do separate videos that have walkthroughs of specific questions, but this one is going to be really focused on how to use the manual and what the guidelines say, okay? So what is E&M? So E&M is evaluation and management. This is the first section of the CPT manual. And these are the codes that are for the actual encounter. It's for the provider's time, decision-making, consultation services, basically things that are not procedures, right? So if you just go to the doctor's office, that is an E&M service, okay? E&M has 3 sets of guidelines. So remember in ICD-10, we had all the guidelines at the very beginning, right? And then we had some excerpts of those guidelines throughout the manual. While in the CPT, each section has its own guidelines. They're not nearly as long as you're used to with the ICD-10, but they are placed at the front of each section. So E&M section itself has 3 sets of guidelines. They're just a couple pages each, but there's guidelines that are for all E&M services. So that apply to everything in this section, and that's what we're going to look at today. And then there's guidelines that are just for hospital observation, hospital inpatient. There's a big long list of services that are covered under those guidelines. And then there's guidelines that are for office or other outpatient services. So basically, there's guidelines that are specific to outpatient office type services. And then there's guidelines that are specific to like hospital services, retirement home, rest home type services. So things that are not necessarily office services, okay? So, but today we're just looking at the guidelines that apply to all E&M services. All right. So I'm going to jump over to the manual real quick so we can look at this. And we'll also look at the guidelines themselves. But before we get into that, I do want to kind of explain what leveling is. You'll hear that a lot. You'll hear that not just in my videos, but if you look at any other videos, if you're just reading resources about E&M, you'll see leveling a lot. And that is when we determine the code that is used from a specific section. So each E&M section, each category or subcategory has different levels. So different codes that really relate to the complexity of the service. And when we're determining which one of those codes is appropriate, it's called leveling. Now that might not make any sense when I just say it, but now I'm going to switch over to the book itself and we'll look at it a little bit more, okay? So let me switch over. Okay, so I'm going to try to get all these wires out of the way. So we have our CPT manual here. As you can see, 2022 version. Hopefully that's what you're using, or at least the 2021. The reason why that's important right now, not just because that's what you can use on the national exam, but E&M services specifically changed, the codes changed in 2001. So the way that we apply them just became a little bit different. So hopefully if you are studying CPT right now, you are using at least 2021. I'm sorry, did I say 2001? 2021 or 2022, okay? All right, so we will flip up to the E&M section. That's our very, very first section, starts on page 1. And this is where we have our table of contents. Now, you might remember me telling you in the video, kind of the overview of CPT, that I code heavily from the table of contents. And the more we do examples of that, the more it'll make sense. But especially in E&M, coding from the table of contents is super easy, I feel like. Now you can, if you want, you just like in the ICD-10, you can use the index in the back, and you could come in here and say you wanted to find an office visit. You could definitely come in here and there would be some reference for office visit, and it would send you to a section of codes right here at the front. But I find it easier if you know you're going to be working in this section, you know, you're going to be, it's office visit. That's pretty much only going to be in E&M. You will come in here. You will find, now the first page is the table of contents for the guidelines. So that helps you narrow down which part of the guidelines you want to look at. But services start here. It says E&M. Office or outpatient services, and then it breaks it down by new or established patient, which we'll get into, and it sends you directly to the right page. So it'll be 19 or 20. So for me, it's easiest to go to, if I know I'm working in E&M, look up the section I want to be coding from here, the table of contents, and go straight to it. But you can definitely use the index if you find that most comfortable, easiest for you. But what you'll see me do most often in these videos is coding from the table of contents. So starting on page 5 are the guidelines for this section. There's a guidelines overview. This is very helpful. I would definitely review it if I were you. And then we get into the guidelines that are common for all E&M services. So this is what we're going to be mainly looking at in this video. So I wanted to show you where that is. Super, super helpful. And then on page 9, this is what I was talking about when I said that big long list of things that wasn't outpatient. So that's hospital observation, inpatient consultations, emergency department, nursing facility, all these different things. Okay. So there's specific guidelines just for those. And again, it's just about 2 pages. It's not a huge long novel of guidelines. It's just a couple pages. And then on page 13, we get to guidelines for office or other outpatient services. Okay. And again, it's just a couple pages. It's not huge. But it's enough that it's important to make sure you're familiar with it and understand it. And I would just take it one section at a time, okay? Because it is a lot to take in, and make sure you're practicing those kinds of problems after you are reviewing those guidelines, okay? So I wanted to kind of show you what I meant when I was talking about leveling and categories and subcategories and what all of that meant, right? So we get to codes for E&M on page 19. This is where our codes start. Okay, and you'll see this is usually the category starts with is in green, and then the subcategory is in red, and then there are codes underneath. So here's the main category is in green, subcategory is in red, and that kind of pattern repeats itself throughout. So what you'll notice in under each red section, there's going to be just a few codes, usually not a ton, and they are all very similar, right? They are talking about the same thing, pretty much the same service. But what is different about them is the complexity. Okay, so usually, so if we're looking at subsequent hospital care, okay, each one of these codes underneath is talking about subsequent hospital care. Okay, so it's the same thing, but what's making it each code different is the complexity. And we'll get into these specific codes later, but just for explanation's sake. So 99233 is high complexity. 232, moderate complexity. 231, low complexity. Okay. So you would, even though these are talking about the same service, we're talking about the complexity of the care that was offered. All right. So picking which one of these is appropriate for the circumstances is called leveling. All right. So that is what leveling means. It means you're in one of these subcategories, you have the same code or the same kind of code for the same kind of service, and you're picking the right level. All right, which correlates with a specific code. So that's what leveling is. I'm going to switch back over to our PowerPoint so I can make sure we stay on target here, because there's a lot we could talk about, but I want to keep us on track. Okay, so something that's important to note, and this is listed in the guidelines as well, it says levels are not interchangeable. So what does that mean? So like when we are looking at subsequent hospital care, if we have subsequent care here, that's what this subcategory is. And then the category before it is initial hospital care. Okay, so these are very similar services, but what it means when we say levels are not interchangeable, what's going on with the very first level, the very first code here under initial hospital care is not the same thing as what is happening in subsequent hospital care. So these are not of equal in complexity, intensity, anything like that. If we're going by time or anything like that, they are not interchangeable. So you should never say, oh, I was going to use this code, and then we need a subsequent hospital care code. I'm not going to look at the documentation to figure it out. I already knew what level it was going to be here, so I'm going to use that level, that same level for a subsequent. They're not interchangeable. You need to review the documentation and make sure whichever level you're picking is justified by the documentation. So that's what that guideline means. Okay, let me switch back over now. And we will get lots and lots of practice with leveling, so don't worry about that. Okay. So new and established patients. So for some categories, quite a few categories, you will need to specify if the patient is a new patient or is an established patient. And this is not limited to just whatever the provider decides. They have very specific definitions, and your national exam will try to trick you. So it's important to understand what new patient means versus established. Okay. So a patient is considered new if they have not received any professional service. So professional service is something that's face-to-face with a provider who can report E&M code. So usually the doctor, a nurse practitioner, physician's assistant. So they have not received any professional service from the provider or a provider in that practice who's the exact same specialty and subspecialty for the past 3 years. So what does that mean? That's a lot, right? So if you have a doctor and you haven't seen them in a while, but they did fill out some paperwork for you. Maybe you had an insurance form that needed signed. They signed it for you 3 years ago. But other than that, you haven't seen them in 4 years. You would still be a new patient when you went to see them, because it has to be something that's face to face. And a professional service. So something that they are seeing you in office for medically, right? So them filling out paperwork, doing a referral, anything like that is not going to count. Now, if you have seen a different provider in that same practice, so say there's a big office and they've got dermatologists and they've got general practitioners and they've got some other kind of specialist in there, and you saw a different provider there, same office, but they have a different specialty or a different subspecialty, you would still be a new patient when you went back to your first doctor. as if it's been more than 3 years. Okay. So that's what we're talking about. We're talking about a new patient. You have to have seen that provider or a provider that has the exact same specialty. You have to see them face to face within the past 3 years. Otherwise, you are a new patient. An established patient is kind of it's basically the exact opposite. If you have seen that provider or a provider of the exact same specialty in the past 3 years for a professional service, you're an established patient. Okay. Some unique circumstances that might come up. So if your doctor is out of town and another doctor is covering for them, and you see that doctor during that time, it would be as if your doctor had seen you because they are covering for your doctor. Okay. Another circumstance that might come up, say you're not able to get into your doctor, but you can get into their nurse practitioner or their physician's assistant, that would still count as seeing your doctor. So you would still maintain that established patient status. Of course, if it's been more than 3 years, no, you're not the established patient anymore. But we're saying within 3 years, that's kind of the window that we always talk about when we talk about new or established patients. So within 3 years, have you seen your provider, a provider of the exact same specialty, or your provider's nurse practitioner or physician's assistant for some kind of professional service? Then you would be the established patient. If you haven't, you're a new patient. And this applies to all E&M codes. And you'll see them in lots of different categories throughout this chapter. You'll see new or established, and these same qualifications apply regardless of which section you're working in. Okay. The only time where we do not worry about new or established is going to be in the emergency room. There's no distinction between new or established patients, even if the documentation specifies we see this patient every week. This patient comes in every day for something, which there are some emergency rooms where they have repeat patients who come in every week. They have maybe an indigent population that comes in for primary care services for whatever reason, and they see them often for very minor issues, or maybe very serious issues, or for management of very serious issues, because there are not other providers in the area. That does not affect how we code. All patients are coded exactly the same, regardless of their history of treatment in the emergency room. Okay, so we would use the same codes regardless. All right, time. So time can also be a tricky thing. Time is one way that we determine the level of service provided. So every category has a different definition or expectations for how to use time. And this is kind of a big change that happened in 2021 that I was talking about, when we were looking at office or other outpatient services. Prior to 2021, you couldn't just use time as a way to determine the right level. Now you can. Now, if the documentation says we spent 20 minutes with the patient and provides a lot more detail, you can just use that 20 minutes to determine the right level for an outpatient code. Previously, you could not. But every other section, well, really every section has specific expectations around how to use time. So it's just very important if you are going to be using how to use time. Okay. Time is not used in the emergency department. The reason why is because time is very inconsistently applied in the emergency department. It really depends on so many different factors, how many physicians are available, if there's a crisis. It can just really vary. And so it's not a good way to measure the level of service that was provided. So it doesn't apply to the emergency department. But the big takeaway here with time is to always consult the guidelines before you use time to select level. It's one of the easiest ways to do it. It really is, but it's just important that you know what you're doing and how to correctly apply the guidelines. So I'm going to switch back over to kind of show you how you can do that. So if you are looking at your guidelines, first of all, I wanted to point out on page 7, there is a decision tree for newer established patients. Definitely read through this. It is super helpful in clarifying if a patient is new or established, and just makes a lot of sense. So I would just pay attention to this. Here's the guidelines for time. Yes, it is a lot. I think once you get started using time as a way to level, it makes a lot more sense, and it's actually very intuitive. It's not like super crazy or anything. But I would draw your attention to page 8, and this lists a lot of different codes and code ranges that have some specific circumstances related to how to use time. So just be mindful. And it tells you the category that it's from. So I would just, highlight that, underline it. So that way, if you are going to be using time for these sections, just review the guidelines. It's just, a little paragraph here, but it does help you select the correct one. And once you've done it a few times, it makes a lot of sense. Like I said, it's very intuitive, so it's easy to apply. Okay. So that is how we use time. And again, when you are applying it, you will come in here and you will read through the definition of the code that you're going to select. So like say we know we're doing an office visit for a new patient, and like I said, I think I said 20 minutes. You would come in here. It says when using time for code selection, 15 to 29 minutes of total time is spent on the date of the encounter. So we know we spent 20 minutes for a new patient office visit. Here's how we figure out the time, and that will help us pick the level. Okay. And so each code that allows you to use time will have the time range specified in there. But what's important to understand is that these are not going to apply to every category equally. Not every category has 15 to 29 minutes. Some of them will have all services up to an hour or greater than an hour or things like that. So it just varies. It's not all equal increments. It's not always 15-minute increments. So that's just important to understand whenever you're looking at the code. So like you can see here, on this subsequent hospital care, it says typically 25 minutes are spent at bedside. And so that's going to have very specific application because it's typically 25 minutes are spent at the patient's bedside. So that's going to be a face-to-face service. Okay. So I'm not saying that to confuse you, overwhelm you. I'm just using that as an example of there's very specific ways that we apply time based on the subsection. Okay. So before I used this code, I said, oh, I had to use 25 minutes for subsequent hospital care. I'm going to select that code. Before I did that, I would go back and check the guidelines to make sure I understood exactly how time is applied in this section. Okay. But that's how it goes for every single section. If time is listed in a section or a subsection as a way to pick a code, then you need to go ahead and review the expectations for how to use time in that section. Okay. And like I said, again, here we have here's typically 40 minutes are spent at the patient's bedside. So again, these are not predictable increments. The other one was 25, this one's 40, and they're at the same level. I think both were at the second code in the section. So they're not using a uniform standard for time, okay? And they have very specific requirements and expectations around how we report time. So the moral of the story is check the guidelines before you use time as a way to pick the level. Okay. Yes, you can. You just need to understand how it should be applied in that section. And how do we do that? By coming back to the guidelines and reviewing the expectations. Okay. And that's going to be here on page 8. So I would come in here and I would review page 7 and 8, make sure I understood it. And then I would probably come in and check the specific guideline for that section as well. Okay, because like I said, we're just looking at the guidelines that are applying to the entire E&M section, but there are section specific, so category specific guidelines as well. All right, it's a lot, guys, but it's going to make more sense as we do it, I promise. Okay. Like I said, consult the guidelines before using time to level any service, but especially hospital, nursing facility, care plan, anything that is split. That is complicated. We will get into it later. But basically, anytime you're going to use time, just go ahead and consult the guidelines. Okay, so concurrent care. This is another guideline that applies to the entire E&M section. Basically, if multiple providers are providing the same or similar services to the same patient more on the same day, that is okay. That's what this means. So usually this is talking about like hospital visits or hospital care. You might see a provider, multiple providers that are in the same specialty. You might see them on the same day. So you're there, it's a very serious case. And then your provider sends his colleague later in the day to check on you and provide the same kind of service. That's totally okay. That's completely acceptable, and they can still report those services. It does not have to be a transfer of care, which is our next thing. So a transfer of care only occurs if one provider agrees to completely take over the care of a patient. And that does happen, and that's totally fine as well. But what we're talking about when we are talking about concurrent care is when that hasn't happened yet. So if your doctor is seeing you at the hospital and sends his colleague later in the day to check on you, they can both code for those services, and that's completely fine. If your doctor is transferring your care to another doctor, that is also okay. And they can just transfer the services over. The specification here in the guideline says that a consultation, they should not be coding for a consultation unless it's a very complex case and you have to do a consultation before the transfer. So if you transfer the care and then you consult with your previous doctor, they're not going to bill you for that. Okay. But if they do decide that, hey, it's a super complicated case, let me get you up to date, give you a consultation evaluation, and then we'll transfer care, then yes, they can bill for that circumstance. Now, what I just said, it's very complicated, right? And it just seems very, very specific, and it is. So I don't want you to get too bogged down in that. I'm just trying to go over the guidelines that apply to all of the codes in this section. So if you are overwhelmed or confused by what I've just stated, just put it out of your head for now. If we get into this situation, we'll review the guidelines again, okay? Counseling. So the only thing that's important to understand, I mean, there's a lot that's important to understand here, but it's just what I think is most important to understand is that when we talk about counseling with E&M services, we're not talking about therapy, okay? This is when we're talking about patient has cancer. We're going to talk with the patient and their family about treatment options, prognosis, what kind of behaviors can change in order to help reduce the risk, those kinds of things. That's what we talk about when we're talking about counseling. That's not the same thing as therapy. So don't get those two things confused. We do have separate codes that are for therapy, but they're not here in this section. Okay. And then this guideline is just explaining that when you're reporting E&M codes, you can still report other CPT codes. So maybe there's an office visit and there's also some kind of procedure that is done. You can report both separately. That's fine. The second part, which is about a test, we're not going to get into that too much today because I don't want to overwhelm you with it. But we will get into how to report interpretations of a test and E&M codes at the same time at a later date. But the main thing to understand from this guideline is if you are reporting an office visit, an inpatient visit, anything like that, you can still report other codes from other sections of the CPT manual, okay? These are not exclusive. You can't, it's not that you can just use E&M codes or you can use other codes. You could use them both on the same day for the same patient, okay? All right, so I'm gonna switch over to the manual one last time because that's all I have on my PowerPoint. And I'm going to do kind of a quick review to make sure we hit the highlights because I know I just threw a lot at you and it's probably super confusing. So what are the basic takeaways from this? These are the table of contents. This is the table of contents. This first page is the guidelines. So this helps you figure out where in the guidelines you need to look. Okay. Starting on page 2 is for the actual section of E&M. There's all kinds of different sections and subsections. Okay. So if you know which section of E&M you're looking for, you know you're going to be coding hospital inpatient service. You know you can come right down here. And then if you know even more specifics, if it's a subsequent service or initial service, you can find that section here. It's very easy. And you can go right to the correct page. All right. So that's how I will usually code in these videos, is from the table of contents. If you do not like that, you can come to the index like you would in the ICD-10. This index is not as well cross-referenced as the ICD-10. However, you can still come in here. It's got office and other outpatient services, consultations, established patient, all kinds of different things in here. And it'll send you to a code range. All right. You would just need to know where that code range is, because this book does not necessarily go in numerical order. Okay. Because you can see we're looking at 99 codes. So that's not the smallest number that's available in this book, even though it is at the very beginning. So you just need to know where that might be located. So you can still code from the index if you'd like, or you can come and code from the table of contents. Starting on page 5 is where you get the guidelines. The guidelines are very useful. Please read through them. Even the overview is very helpful. Make a note here. Here's the decision tree. Okay, new and established patients. A new patient is going to be, in fact, let's flip up here to our codes. So you can write these same notes in your manual if you'd like. And has not seen or has not had professional service in 3 years. Okay, in the last 3 years. That's what a new patient would be, if you can read that. An established patient has had a service in the past 3 years. Okay, so if you need to write this every time you see new and established, great, go through and do it. The other note that we had was about emergency services. Now, when you come in here, it'll show you at the beginning of this section and also in our guidelines, it said no distinction is made between new and established patients in the ER. So I would note that, bring attention to it. So that way you're not worrying about that when you use this section. Okay, back to our guidelines. Time. Here's our section for time. It starts on page 7 and it goes on to page 8. I would make sure you know these exist. You don't need to know exactly how to apply them, but know that they exist and know to check these before using time to level any service. Okay. Concurrent care and transfer of care. We talked about that. Concurrent care means two providers or more providers provide the same or very similar service to the same patient on the same day. That is acceptable. You do not need to do any separate or unique kind of coding for that scenario. Okay, transfer of care is when one doctor transfers the responsibility of a patient to another provider. Okay, that is also acceptable. And we'll get into what consultation means and all that again later. I don't want to bog us down with that again. Counseling. What does counseling mean? It is not the same thing as therapy. So just put not therapy. And in fact, there's a little note here that says for psychotherapy, please see these codes. All right. It is not the same thing as therapy. We are talking about when we talk with the patient or their family about all kinds of different things to help with that patient's specific medical condition. Okay. That's what counseling is referring to. All right. Services are reported separately. What we want to get from this section right now, we're going to get into more details on how to do all kinds of different things with reporting separate or reporting significant, significantly more than anticipated services, stuff like that. We're going to get into all of that later. But what you need to know today is that you can use other CPT codes and E&M codes at the same time. So I'd put a note maybe down here. Okay, so I make that note for myself. That helps me understand that this is what I need to know from this section. Okay, so that's all we're going to cover for this video. I'm sure you're thinking, oh, that was a ton of stuff. Yes, it was. But later we'll get into guidelines for all of these different sections and outpatient guidelines. Okay. But that is all we are covering for this specific video. If you have questions, concerns, please let me know, put them in the discussion and we will work through them together. Thank you all. Bye-bye.